Hi guys, welcome back. Today we shall be talking about obstructive sleep apnea. Who doesn't want a good, comfortable sleep? Though we doctors are half the time sleep deprived. But today I'm talking about those people who are having a increased daytime sleepiness, and the reason for that would be that at night they would be having these recurrent cortical arousals, which are secondary to the disease that we are studying by the name of obstructive sleep apnea. Let's focus on these images so that you can get an insight into why this person is never waking up fresh in the morning. This would be a morbidly obese individual, or I would say at least an obese individual with body mass index of more than 30. And let's look at how his breathing at sleep would be different as compared to you and me. Now imagine yourself lying in the bed in a supine position, and you obviously have a normal airway, so air can obviously take its normal route. And in normal people like you and me, we have what is called as the pharyngeal dilator muscles, and they prevent the tongue from falling backwards when we're lying in a supine position, and they keep our airway patent so that we are having a normal delivery of oxygen to the lungs and then to the rest of the body. What happens with respect to people who are having obstructive sleep apnea would be that the normal sinusoidal inspiration and expiration that occurs in you and me will not be happening. If you look at the second diagram, you will notice the fact that in this individual, the tongue is slightly falling backwards. Now, you are all aware of the fact that REM phase of sleep is when the tone of the muscles tends to basically reduce. I mean, this is a stage when you if have a dream which is scary, I would say, like a horror kind of a dream, then in a normal individual you might feel as if your body is paralyzed. So REM phase is whenever muscles are taking rest. That is the part of the sleep where the tone of our muscles is the least, and that is what happens in this particular individual, that the tone of the muscles is obviously reducing, but to a level that it is causing a narrowing of the airway. You can very well notice a very significant narrowing of the airway in this individual, which will contribute to development of hypoxia. So if we evaluate how in this particular individual the breathing will occur, these people have a sharp inspiratory uptake. Then there's a rather a plateau of breathing, and then there would be I would say a scooped out pattern of breathing. What I mean by scooped out pattern of breathing is that unlike a normal sinusoidal representation of breathing, in these patients, if you check out the inspiratory and the expiratory effort, you will notice that the inspiratory part is first rather vertically steep, then there is a flattened pattern, and then obviously there's a scooped out appearance that would be very visible even on a polysomnography when we record the nasal airflow for these patients. So in this particular patient, what I have shown is technically called as flow limitation, which explains the fact that there is hypoxia in the body and that can contribute to cortical arousal. Now, if I go to the third image, you will notice that in this person, the magnitude of obstruction has increased even further. So I'm drawing a relatively thicker arrow to say the fact that the tissues, the soft tissues, are rather falling backwards. This could be secondary to obesity. It could be secondary to people who have a small jaw. So I don't want you to be under impression that snoring is found only in very fat people, or you get obstructive sleep apnea on only very fat people. People who have, I would say, micrognathia or retrognathia, that means the mandible is not very well developed. The mandible is smaller as compared to the size of the tongue. Even those people could be having this kind of a loud snoring. So you can notice the narrowing of the airway, and when the air tries to go in, it will result in this vibrations of the soft tissue, especially of the uvula. So you have is a characteristic loud snoring in this individual, and as the airway gets progressively narrowed, the intensity of snoring will increase. So family members are gonna say, like, this individual, when this person is sleeping, we feel as if there's a tractor running in the house. Maybe sounding funny to you, but that's how the relatives will say. I mean, loud snoring progressively increasing, like there's a tractor running in the house and I just can't sleep. So maybe his wife is complaining that this person snores too loudly. There's vibration of the soft tissues that you can see, and then the bad thing happens, which is that there is absolutely no flow. So I've just symbolically shown here is a development of an apneic episode. I will explain to you the definition of apneic episode, but at this moment, I want you to get a hang of what is going to happen in this individual, which is that unlike a normal individual with a normal sinusoidal inspiratory expiratory flow, there is a significant flow limitation. There is a development of loud snoring in the patient, followed by an apneic episode in an individual. Now, why, as a doctor, are you worried about an apneic episode? Apneic episode will contribute to development of bradycardia. Look at this guy. When you would be doing a polysomnography in the individual, you will notice the fact that during the phase, because in polysomnography you record ECG also, so you will notice a decrease in the heart rate of the patient. The oxygen saturation is falling, and due to this hypoxia, now there will be a cortical arousal. This cortical arousal does not mean that patient is gonna wake up like a normal individual will wake up, but yeah, this person might change his position in the bed. He would be, restless person in the bed. His partner might say that the person tosses around, and then due to this cortical arousal, there would be a particular grunting by the patient. You can see that there is no delivery of oxygen, so the person will grunt. So I'll try to make that sound. The sound would come something like this. I'll try again. That's kind of sound, the grunt that will come. And look at what happens when the person will grunt at the end of this apneic episode. It will cause opening of the mouth of the individual, which will forcibly send air, and therefore due to the opening of the mouth of the individual, because some air is going to go inside into the airway of the patient, that is when the oxygen saturation will definitely jump up in the body. That is good news, but it will put a tremendous load in the heart. You can see that almost there's a doubling of the heart rate of the individual when he's grunting, and that will put a lot of load on the heart. So a lot of these patients will end up with development of left ventricular hypertrophy, because there's a lot of load on the heart, and left ventricular hypertrophy or left ventricular strain is what is usually encountered in these patients. Do remember my statement for MCQ that in this particular disease, right ventricular failure is unlikely or is least likely or usually is not seen, but yeah, left ventricular strain and left ventricular hypertrophy is obviously noticed in these patients. And not only is you are having stress on the heart, even other body systems are affected because the body is not getting rest. Why? Because when we are sleeping, we don't have cortical arousal. So if you are going to awaken multiple times in the night, that's definitely going to cause extreme fatigue at the daytime. So these people are going to say that, doctor, I never wake up fresh. I wake up as if my all body is hurting. In fact, when I wake up in the morning, the thought process of this guy is, when will I get to go back to sleep again? So do appreciate the fact that we as doctors are sleep deprived. We work extra hard. We do night shifts. We have a disordered sleep pattern. So we are having, I would say, a fatigue that is, I would say, different from what these people are having. And in fact, as studies are shown now, obstructive sleep apnea is gradually going to become the most important cause for hypertension. It's going to contribute to development of secondary hypertension, though currently the leading cause is renal causes. But the way the incidence of morbid obesity and obesity is increasing in India and in the Western world, in the forthcoming years, obstructive sleep apnea will be one of the leading reasons for hypertension. And yeah, this disease definitely increases cardiovascular mortality. That has been very well documented. I mean, if you notice increased neck circumference, you and me can put a shirt button collar, but if you are noticing an individual with increased neck circumference, obviously abdominal circumference increased is feature of obesity. Increased neck circumference is again itself a risk factor for development of obstructive sleep apnea in a patient. So you can notice a straight jump in the heart rate of this individual once the cortical arousal will occur, because obviously the body will try to take care of the hypoxia. I will explain to you how to interpret polysomnography. But at the moment, I want you to remember my words that polysomnography is the investigation of choice for diagnosis of obstructive sleep apnea hypopnea syndrome. I'll explain the meaning of apnea and hypopnea in few minutes from now. I also want you to look at the readings right now. You can see that in these individuals, we monitor the nasal flow rate. We put a strap around the chest to measure the chest expansion. We put sensors around the abdomen to check the abdominal movements. And you will notice the fact in this individual, when he's not breathing, then at those particular point of time, when he's not breathing, when he's having apnea, you can notice a dip in the oxygen saturation of this particular individual. And once the breathing resumes, he might have a slightly increased inspiratory effort once there's a cortical arousal. But every time there is a apneic episode occurring in a patient, there's a very perceptible decrease in the oxygen saturation of the patient, and if the oxygen saturation decreases by more than 3%, then we definitely are bang on track for diagnosis of obstructive sleep apnea in a patient. So let us just summarize the aspects that I have said before you for OSAs so that we get going for solving the questions related to this particular topic. Obstructive sleep apnea has increased daytime sleepiness, increased incidence of cardiovascular mortality and cardiovascular disease. In these patients, in fact, the disease could be present since birth. So even children can be having behavioral issues due to obstructive sleep apnea. Now, what is the definition of the word apnea is obviously important, and you should also know what is the definition of hypopnea, but first apnea. Well, apnea simply means absent breathing. The cutoff or duration for the same has been asked in multiple choice questions. So absent breathing effort for a duration which is lasting more than 10 seconds. That's the first and the foremost thing that you need to remember. This will be associated with approximately a 3% decrease in the saturation of oxygen in the body of this particular individual that can be measured by pulse oximetry. And then there should obviously be a cortical arousal. How would you check for cortical arousal? You would check for the EEG of the patient. Like he's in REM sleep. REM sleep would normally be having a sawtooth pattern. So there would be a change from sawtooth pattern to alpha pattern. Alpha is when the person is with eyes closed, but there's a cortical arousal present. But when person is in REM sleep, we tend to have what is called a sawtooth pattern. So there would be marked changes in the EEG of the individual. And due to this repeated cortical arousals, that is why I said these people are never fresh in the morning and they always feel tired. And they say like, I have never got a proper sleep, doctor. And when I wake up, first thing I want is when can I go back to sleep again? That's the usual manifestation. Now let us look at the definition of the word hypopnea and compare this with apnea per se. Obviously, as the name suggests, hypopnea, so there would be a more than 30% decrease in the airflow. We can obviously monitor this by checking the nasal airflow by monitoring the response in the nasal airflow sensor, where you will notice a flow limitation in the patient. So more than 30% decrease in airflow for a duration of more than 10 seconds is called as hypopnea. This should obviously be associated with the same thing, that is a 3% decrease in the oxygen saturation of the patient, and would be associated with a cortical arousal as is written on the left hand side. So I would say hypopnea is one step lesser as compared to apnea in an individual, but this is definitely a cause of concern because the body is not getting sufficient rest in these individuals. So let's work out now the definition of obstructive sleep apnea hypopnea syndrome. First and the foremost should obviously be presence of symptoms. While I'm writing them, please remember obstructive sleep apnea can occur even in the absence of symptoms. So that's not a prerequisite or an essential thing for diagnosis of the patient. Well, what will be the symptoms? Nocturnal symptoms in the individual are obviously going to be loud snoring. Then could be grunting, which is usually towards the development of an apneic episode, or instead of grunting I can say the word snorting, and breathing pauses. Lots of time the partner of this individual, the sexual partner of this individual would rather give this history that I've noticed that my husband or my boyfriend or whatever, I mean the individual will say that my partner is not breathing normally. So there are breathing pauses of the individual, and that is of concern, which this person is obviously not realizing. Now at daytime, what will be the symptoms in the patient? There would be increased daytime sleepiness. I have had patients who have told me, in fact, I've had medical students with obstructive sleep apnea who said, sir, that if you give me permission, I can sleep on the table. That drowsy. He says, forget about attending a class in a medical college. He says, if you give me sleep now, I'll sleep on the floor. So these people can sleep anywhere. In fact, they can sleep at the wheels of a car, driving a car. Now imagine in a Delhi traffic where even if you miss your clutch by 1 second, if you delay putting your car in the first gear at a green signal for even 5 seconds, people start blaring their horns from your backside. Here, if this person fell asleep on the wheel of a car, and people were honking on the backside, and that's when he realized that he's sleeping at a traffic signal. So that's obviously cause for concern. A lot of these people might actually tell you that I don't feel comfortable driving. I think I might have an accident, and they've given up driving primarily because their attention span that is required for driving will be compromised. So the second thing which is important for presence of obstructive sleep apnea is measured by polysomnography. That is, there should be at least 5 episodes of apnea that should be demonstrated in this individual per hour of sleep. So if we are able to identify these two basic problems, that is symptoms in the patient and more than 5 episodes of apnea per hour of sleep, it means that the person is having obstructive sleep apnea hypopnea syndrome. Now I'll say a special point which I want you to understand, that if the apnea hypopnea index, how do you calculate apnea hypopnea index? Number of apneic episodes divided by total number of apneic episodes in the entire sleep divided by the number of hours of sleep. Like suppose there were 40 apneic episodes in 8 hours of sleep. So apnea hypopnea index would be 40 by 8, that would be 5. So we can just have to calculate the total number of apneic episodes in a particular duration of sleep, which is 7 hours, 8 hours, 9 hours, depending on whatever is the normal cycle of the individual, and calculate a AHI. If the apnea hypopnea index is more than 15 episodes of apnea or hypopnea which are demonstrated in an individual per hour of sleep, even minus the symptoms. I would like to highlight this because of the fact that a lot of people may not be symptomatic or they may not be aware of their symptoms, but yeah, their partner noticed that they have this breathing pauses, or they might just give you non-specific complaints like this man is having erectile dysfunction, and he came to you for erectile dysfunction. You found he's hypertensive, he's putting on weight, he's having a cardiometabolic syndrome, and then you found out that this individual is having obstructive sleep apnea. So it started from a problem in the sex life and ended up with the development of OSA in individuals. So you'll have a lot of middle-aged men, especially 40 to 50, especially Indian men coming to you with erectile dysfunction secondary to this disease. And later on, you will notice the fact that this person was having obstructive sleep apnea. And you will notice one more interesting thing. You see, these people will tend to put on weight even much more than what they were initially before the disease started. Why? Because if the person is sleepy all the time, he'll sleep obviously, and sleeping means that there would be less caloric expenditure by the individual. So the weight of these patients will show a progressive increase. So once we remember the diagnostic symptoms for this particular condition, then is the time for working out what are the risk factors for development of this particular condition. Well, one of the most important risk factor is obviously centripetal obesity. Now, why is obesity contributing to this? Then I can divide this discussion further into two parts. Point number one would be that there will be narrowing of the lumen of the upper airway. That's obviously because of the fat deposition in the upper airway of the patient with respect to the uvula or pharyngeal wall. So narrowing of the pharynx, I would say, or narrowing of the pharyngeal inlet is one of the reasons why you would be having snoring and would be having a obstructive sleep apnea developing in this individual. The second reason would be that there would be a reduced compliance of the chest wall, the expansion capacity of the chest. You see, our diaphragm generates a force which would help you to inflate your lungs. Due to the obesity, the compliance of the chest is lesser. So the pull that is required to keep the airway patent during inspiration is hampered in this individual. I said two things: narrowing of the pharyngeal inlet due to fat deposition, that is one of the reasons. The second would be decreased chest wall compliance, which would decrease the caudal traction. Mark my words there, caudal traction, which is required for keeping the airway patent. And therefore, we are saying that there is a collapse of the airway. Upper airway does not have any cartilage. I mean, it's not a stiff area that like trachea has these cartilaginous rings which keeps it patent all the time. But in this case, due to obesity, the patency of the upper airway is compromised, and that explains the fact that obese people would be having a higher incidence of development of obstructive sleep apnea. Now I am showing you a very thin person. In this particular person, you will notice the fact that the mandible is not even properly developed. So people with craniofacial abnormalities, especially a disease by the name of micrognathia, are at risk for development of OSA because the tongue would be disproportionate to the size of the mandible. So it's obviously bound to fall backwards during the phase of sleeping, especially REM phase, where the pharyngeal constrictor muscles are not working properly and the airway obstruction would occur. Sometimes you will notice that the examiner will write the word retrognathia and sometimes they will write the word micrognathia. So obviously you should know the meaning. Micrognathia, as the name suggests, simply means there is a mandibular maldevelopment, there is a mandibular hypoplasia in the patient, which would be responsible for problems in the patient. On the other hand, when I say the word retrognathia, it means there is an abnormal mandibular position with respect to the maxilla, because our maxilla and mandible are aligned. But if you have an abnormal mandibular alignment with respect to the maxilla, WRT means with respect to the maxilla, then it implies the fact that the patient is having a retrognathia. In the next image, I have shown a syndrome here. You would definitely notice that this child, partially open mouth, protuberant tongue, mongoloid slant. These are very characteristic features that are seen in children with Down syndrome. So even children with Down syndrome have a protuberant tongue and would be having an incidence of obstructive sleep apnea, which explains behavioral abnormalities noticed in children with OSA. Then would be relatively a rare pediatric condition that's again related to mandibular and the maxilla alignment, that is Treacher-Collins syndrome. So these are two important reasons which I wanted to remember from the syndrome perspective. The incidence is also increased in women post menopause or after menopause. That's primarily because they have documented the fact that estrogen improves ventilatory drive. So when a woman is younger, the incidence is lesser, but in a woman who's older than 45, lesser amount of estrogen, the respiratory drive is relatively lesser, so incidence increases in women. Then you can notice macroglossia with a broad nose in this particular patient with coarse facies. So I have shown here an image of a patient of acromegaly. There's a coarse facies, there's a large tongue, and the large tongue would obviously be having a tendency to fall backwards and narrow the airflow and contribute to disordered breathing during sleeping. Hypothyroidism has myxedema that can explain the airway narrowing in the individual and contributing to development of obstructive sleep apnea. During the description, you will notice the fact that most of the time I'm emphasizing on either the obesity component, obviously, which is the most common cause, or I'm rather emphasizing on the mandible and the tongue disproportionate with respect to each other, or for that matter of fact, I'm talking about airway narrowing due to connective tissue overgrowth or myxedema primarily. But I would also like you to remember that people who are having diseases, ENT diseases, like I would say a patient has a high nasal resistance. What I imply by the word high nasal resistance is that this person is having nasal polyps, big nasal polyps, or is having adenotonsillar hypertrophy. So people with high nasal resistance, what happens is because they can't breathe through their nose in sleep, they tend to breathe with their mouth open. And when they're breathing with the mouth open, again what happens is tongue tends to fall backwards. Why? Because if I keep my mouth closed at the moment, imagine if I'm lying supine and my mouth is closed, then the closed mouth will ensure that the tongue is not gonna fall backwards. But if I am sleeping and my mouth is open, then the tongue has a higher chances. So you will notice a lot of these people know later on when you talk to them, they'll start saying like, sir, I wake up with a dry mouth. I wake up with a foul breath. Why? Because if he's breathing with an open mouth, then the individual would be having the saliva would be relatively lesser, and the saliva would evaporate, and therefore the growth of bacteria can also occur. So these people wake up with a dry mouth and a bad smell from the mouth. That comes basically because saliva has bactericidal properties. So what I'm saying is that people with high nasal resistance, that is deviated nasal septum, and even polyps, could be having a development of mouth breathing in the sleep, causing the tongue to fall backwards, and therefore there could be occlusion of the airways of the patient. So these are the usual risk factors which are related with development of obstructive sleep apnea in an individual. Now we will study what are the clinical features with which these patients will come to us. The number one clinical feature has already been explained to you, that is snoring and snorting in an individual. There could be obviously gasping breathing that could be noticed by the family member. Or jokes apart, I mean, family members will always say that when this person sleeps, nobody else can sleep in the house. There was a marriage party in the house and this person was sleeping. Please remember that breathlessness as a symptom will not be encountered in patients with obstructive sleep apnea. Why that is important is not only from the MCQ perspective but clinically also, because if a person is sleeping and he's having breathlessness, then I would be more concerned about whether this is paroxysmal nocturnal dyspnea, or I would be thinking that this person having breathlessness while sleeping at night is having maybe asthma, because asthma attacks tend to occur at night. Why? Because air is colder at night, so bronchospasm would occur. Or this person could be having gastroesophageal reflux disease. So nocturnal dyspnea is something that would be not making you think in terms of obstructive sleep apnea, but make you think in terms of the disorders that I have mentioned before you. Frequent awakening or tossing and turning in the bed. So it's not that everybody will say that I open my eyes and look around, right, when he's awakening, but he will say that I have a very restless sleep, or he's keeping tossing and turning in the bed. So the partner is getting irritated that one, you are producing so much of noise and then you are so restless in the bed. So other person, if the person like next to you is not tossing and turning, you'll obviously bound to get irritated. Then in these patients, there could be history given of dozing off involuntarily. I mean, while talking, that's where the jokes would come in the family. That there's a cricket match going on. Virat Kohli is scoring a century, and this guy is sleeping. Or Modi is giving a speech and this guy is sleeping. So dozing off involuntarily during performance or task can be there. Like this guy could be sleeping at the wheels of a car. So that is definitely a cause of concern in the individual. Then I said these people will usually or can wake up with a dry mouth, with a foul breath, that is halitosis. And because they never get a proper sleep, so there would also be mood swings in this individual. So these are the standard symptoms that you will notice. And I mean, the person himself will say that, doctor, there is something wrong with my body. And yeah, I mean, because I mentioned regarding the sex life of these patients getting affected, so mostly male patients would come to you with ED, that is erectile dysfunction. And in fact, that can be a lot of time a primary complaint in the patient. Now let us look at what is going to be the examination findings for this individual. So on examination, when you take the blood pressure of this patient, you will notice that he is hypertensive. This hypertension could be noticed by the hypertension can cause a headache. So hypertension could have been pre-existing to the current symptoms of the individual, or could have developed subsequently. In general physical examination, you will also notice that the abdominal girth of the patient will be increased. There are charts available for that, appropriate for age. There are similar charts for neck circumference that would definitely be increased in the individual. And when you do a ENT checkup, you will notice that either possibility can be that the tongue size is bigger, or you might notice that the mandible of the patient is smaller in size or is malpositioned. That is one. Another possibility could be that the patient could be having a low-lying palate with enlarged tonsils or a bulky uvula. That's the usual presentation that you will notice in obese people, low-lying palate and a bulky uvula. With respect to children, you might notice that the child might be having enlarged tonsils, and enlarged tonsils can also contribute to development of adenotonsillar hypertrophy, as I said, can contribute to the same. So the bottom line is that the cardiovascular profile of this patient will definitely worsen. So cardiometabolic syndrome or syndrome X manifestations can be noticed in this particular individual. For syndrome X, I've discussed separately. You can go through the cardiovascular system for that. And lots of these people would be obviously putting on fat. They'll become obese because they sleep most part of the day. So deranged lipid profile would also be noticed in this individual. Now I'm going to do some workup of this individual so that we can come to a final conclusion. The investigation choice, as I've taught you, is polysomnography. So let us study what are we going to do in the polysomnography. I'm going to tell the patient that you just have to sleep. We are going to record your sleep by putting on some sensors. One sensor that I will definitely put would be on the forehead of the individual on the occiput, and one in the center to record the EEG, because I want to demonstrate a cortical arousal in the patient. I also want to put a sensor near the eyes of the patient to check for, on the eyes of the patient rather, to check for the rapid eye movement, electrooculography. I will also put a sensor on the chin of the patient, because when he's snoring, then there would be this movement of the throat of the individual. So EMG would be done on the chin and would also be done on the leg of the individual. Like we can put a sensor on the leg that can help you know that if he's going to change his position, or if he's going to move his bed, like tossing and turning in the bed, then the EMG will pick up, EMG sensor in the leg will pick up the change in the position of the patient. We are going to record the ECG of the patient because that will show a prolongation of the RR interval, because there would be a bradycardia that would occur in these patients. Then is obviously a pulse oximeter and nasal airflow. These are the sensors that we are gonna deploy in these people to pick up the airflow limitation. Plus we will also record the chest movements as well as the abdominal movements in the individual. We will be able to demonstrate paradoxical breathing in these patients, like our chest expands, here the abdomen will be working more sometimes, and then obviously in apneic episode both will stop working. So sensors in the form of a belt would be put to measure the chest expansion and the abdominal movements in the individual. Along with this, you can also go in for blood pressure monitoring. I want to tell you the fact that when we are sleeping, we normally have a dip in our blood pressure. It decreases by approximately 10%. In these patients, if you go for BP monitoring, you will always notice absence of nocturnal dip. And in fact, that's one of the early manifestations that will develop in obstructive sleep apnea. The blood pressure tends to be rather blood pressure tends to be higher in these patients, and most of these patients are either pre-existing hypertensive or become post-hypertensive to the manifestation of this particular disease. And since there would be a lot of stress on the heart, so echocardiography, a baseline, can be done in this individual so that I can check for chamber size in the patient, because gradually the left ventricular strain can contribute to LVH in the patient. But remember that right ventricular failure is not seen in patients of obstructive sleep apnea. That's an MCQ statement which is to be remembered. Now let's look at few polysomnography records. Like you can notice here that the electrodes which are present on the top, they are basically recording the electrical activity in the brain, and if there's a sudden burst of electrical activity with change of rhythms, it definitely tells you about cortical arousal in a patient. EOG would be recording eye movements. We can identify REM sleep. There's a sensor on the chin to pick up the snoring activity. Then is obviously EKG. Like in America, they don't use ECG, they use EKG. You can have a mic that can record the snoring aspect of the individual. Then is the nasopharyngeal flow, which is important. And in this diagram, you can notice the fact that the nasopharyngeal flow of the patient has shown a decrease, and then there's a proper apnea occurring in the patient. You will also notice that corresponding to the nasopharyngeal flow, which is decreasing, the chest movements of the patient have also shown a declining trend, and there is hardly any chest and abdominal movement in this individual. So definitely the oxygen saturation in these patients will fluctuate, and post you will notice that the person's breathing efforts will dramatically increase, because the person is trying to overcorrect now. Like the person is trying to overcorrect because there is a development of hypoxia in this particular individual. So in this image, you can notice the sensors at the nose to measure the airflow. There are sensors on the scalp, you can notice, to record the EEG. We are doing a nasal airflow recording. We are recording the electromyography of the chin of the individual. And then you can notice this elastic belt sensors, which are around the chest and the belly to measure the amount of breathing effort. You can notice the pulse oximeter in the patient, and all these sensors are then gonna save the data to the hard drive of the computer, and we would then be able to analyze the data in this individual. The bottom line is, and I'll just highlight that very simply, is the fact that whenever there is a happening episode in the EEG of the patient, like suppose there is a development of, suppose this patient is in REM sleep. REM sleep has this characteristic beta pattern occurring. So there would be a conversion of beta into alpha. So there's a change in the EEG pattern of the patient when there's a cortical arousal. Now, when would this cortical arousal be occurring? Because I'll repeat the data once again, guys, and I want you to listen very carefully. REM sleep is called as paradoxical sleep. Why? Because we are sleeping, but the rhythm is beta. And when we have cortical arousal, we can upgrade to alpha in this individual. That alpha will obviously be because the eyes of the individual are closed. So there is a cortical arousal being demonstrated. Simultaneously, in the ECG of the patient, you will notice that whenever there is a hypoxic episode, the RR interval of the patient will get prolonged. That means that there would be a bradycardia that would be occurring in the patient. You will also notice that in the nasopharyngeal airflow sensor, the nasopharyngeal airflow sensor will show a declining activity with respect to breathing in the patient, the abdominal and the chest movements of the individual will also reduce. And when you are checking the electromyography, notice the fact that when snoring is occurring, in the patient, then there will be no movement in the leg sensor because person is sleeping. But the moment the snoring will stop, the person might awaken, they might be change of position, then the leg sensor might pick up an activity. So we have to observe the changes. And well, don't bother in your exam, they're not going to give you any polysomnography recording, though they have done that once in AIMS exam. They simply gave this recording like this and they said what does it represent. So it's a polysomnography, it is used for OSA or for any apnea per se. In the current recording, you will notice the fact that the sinusoidal movement of the chest and the abdomen is definitely occurring in the individual, but in between you are definitely noticing that the nasopharyngeal flow is showing what I was saying would be a scooped out pattern. Then if you look at the infrared recording that is currently shown to you, in fact, I have deliberately picked up this image from Harrison because all of you are aware that we have Cheyne-Stokes breathing in patients of raised ICT. This is Cheyne-Stokes breathing, guys. If you look at it carefully, you will notice that the person is having hypoventilation. Then there is almost an apnea, no breathing. Then there is a hyperventilation. The hyperventilation is followed by again the same thing, hypoventilation. There is a apnea and a hyperventilation. So you can notice that in this individual, this cycle is getting repeatedly I would say the cycle is occurring on a repeated basis. So hypopnea, apnea, hyperventilation, because it occurs on a serial basis in this individual, it explains the fact that this particular chap is having a definitive CNS cause to it. And you can notice that the EEG of this guy is going crazy. That's the cortical arousal that is occurring because secondary to the hypoxia which is occurring in this individual. And the oxygen saturation is fluctuating all the time. Like you can see the dip in oxygen saturation at the apneic episodes, and then maybe trying to return back to normal. So this recording is that of Cheyne-Stokes breathing. As I've said, thankfully till now they have not given any polysomnography interpretation in the exam, but yeah, some of the images are very characteristic and definitely makes sense to at least have a look at them once. So this slide is mainly to explain to you fact like what do we actually do in a sleep study or polysomnography in a patient. Now we will talk about what are the treatments which are available for these patients. Usually the best treatment is a CPAP, like I have shown here a Philips model here. The person is shown sleeping with a mask on, which might be a little bit of difficulty initially because a person might have irritation to the mask. They might be damage to the nasal septum because of the rough plastic tissue of the mask. But yeah, the quality of the products is improving in our country. So this would cost about 30,000 rupees in Indian currency, and the quality of life of the individual definitely become better. So let's look at what are the treatment options available before you as a doctor for managing a chap with OSA-HS. First and foremost is obviously weight loss, but that should be at least 10% weight loss that should occur in an individual to reduce the hypopnea episodes. Just to put it in the contrary sense, I want to tell you that for every 10% increase in the weight, like suppose weight is 80 kg, if it increases to 88 kg, for every 10% increase in the weight, there is a 30% increase in the incidence of development of obstructive sleep apnea. Just by looking at these figures, which is 3 times more, you can understand that whatever is the population of obesity, more than 30% of them are suffering from obstructive sleep apnea. So more is the weight, more is obviously the incidence of it. So weight loss is obviously recommended. Then you have to tell the patient to avoid sleeping in supine position. That's very, very obvious. These people are anyway having a narrowing of the pharynx, which is a collapsible structure, especially in REM phase. So avoid sleeping in supine position is recommended for these patients. Try to sleep on the side. Lateral decubitus is a good idea. The third thing that is to be done for these patients is obviously, regulating sleep time is very important. That going to bed, waking up, good sleep habits is recommended. But if nasal allergy is concomitantly present, like polyps, etc., they have to be handled very aggressively because, as I said, nose resistance is more. He will breathe through his mouth. That again contributes to development of increased incidence of OSA. Avoid alcohol intake at least 3 hours before sleep. I mean, like social drinking in Western countries, no, they drink a lot. So at daytime, we'll say, okay, you can drink, but at night time, before you go to bed, don't take a drink because alcohol will decrease your CNS drive and the incidence of OSA will increase. So avoidance of alcohol intake is also at least 3 hours before sleep is recommended for these patients. And now we come to the specific answer, that is CPAP. When would you advise CPAP in an individual? I would advise CPAP in an individual if there is more than 15 hypopnea episodes per hour, even if there is no symptoms in an individual. And I would advise CPAP if there is more than 5 apneic episodes per hour. So CPAP is recommended for both mild to moderate to severe. Therefore, CPAP is required for most of the patients of obstructive sleep apnea to splint the airway open. As the name is continuous positive airway pressure, it will splint airway open, will prevent the collapse of the airway. The disadvantage of CPAP can be manifold. One can be aerophagia. The abdomen will distend in the morning. So that's obviously a person will get used to it. And sometimes because of this aerophagia, there can be concomitant GERD developing in a patient. So antacids might have to be used in these patients. One of the surgery which is mentioned in the textbook for these patients, though less performed nowadays, is called as uvulopalatopharyngoplasty, which means resection of the uvula. So if you remove the uvula of this patient, you are creating more space, and that's what you require to prevent the collapse of the airways of the patient. So uvuloparyngoplasty is recommended for these patients to minimize the incidence of OSA. Now we have a upper airway stimulation device. It would be surgically deployed. It will stimulate the hypoglossal nerve of one side, which will cause a contraction of the muscles, especially of the tongue. So the chances of tongue falling back would be definitely reduced. So I'll mention regarding this upper airway device, which is deployed surgically. It's a surgical implantation. And the manifestations in this individual would be that it will stimulate the hypoglossal nerve. And the end result would be the prevention of the tongue from falling backwards. There are some oral devices with varying efficacy which are also available. They act by basically repositioning the mandible of the patient. They're very difficult to manage. Sleeping with something in your mouth is not something very comfortable. So oral devices which help in reposition of the mandible, the acceptability of them is also less. The efficacy of them is also very varied. So there is no valid documented study or meta-analysis available which is rather saying that this is superior or inferior, because they've actually not tested them. So they're available in the market obviously, but then the clinical studies documenting their use is not available. So the treatment of choice for this condition is obviously CPAP. Initial treatment would be answered as weight loss in an individual. Disadvantages of CPAP can be aerophagia, getting used to the device, local trauma due to the ill-fitting mask, etc. are the minor side effects that can be obviously adjusted with the help of a good post-sales team, I would say. And now the models are fairly affordable for our Indian patients. So the quality of life in these patients will definitely increase dramatically. We shall now talk about also central hypoventilation syndrome. But before I do that, I want you to be aware of a question which is related more of to psychiatry, but still you should know it. And I'll just mention the name so that you can remember it. This is a patient-filled questionnaire. This is called as Epworth Sleepiness Questionnaire. And well, I would suggest you that if you also keep on feeling sleepy all the time in medical college, back in your medical school, though you sleep well, I mean 8 hours, 10 hours, still you feel sleepy all the time. One could be obviously the class is boring, Second could be that you are under too much of stress, to the class is good. Third possibility is obviously you could be having obstructive sleep apnea. So what will you do? You will fill up this questionnaire, and if the score is more than 8, that means you need medical advice. The questions are like, how likely are you to doze off in following situations, like sitting and reading, watching television? Modi is speaking and people are, I mean, he's a good orator, right? So Modi is speaking and the guy is sleeping. Or I would say like this, that Dhoni is scoring a century, Virat Kohli is scoring a century, or Ronaldo is scoring a goal and the guy is sleeping. That's definitely a cause of concern. Sitting inactive in a public space, like sitting in a park and he is sleeping, or let me say at a party, at a club, the guy is sleeping. So the person will have to fill this up. There's mentioned like as a passenger in the car, he's tending to sleep, or at the wheels of a car he's tending to sleep, both, right? So if the score is more than 8, that definitely means that the person needs medical care, and a polysomnography should be done in this individual. Before I talk more about central hypoventilation, guys, I also want to just introduce to you, this is not academic, but I just wanted to introduce you to this young chap. His name is Nitesh Kumar, and he has developed a portable CPAP device specially useful for babies, and he has also developed a model for adults for reducing the incidence of ventilator-associated pneumonia. Because in India, if somebody goes on ventilator, we are thinking that when will the person die? Why? Because most of the time the tubings are contaminated, and the hygiene part cannot be maintained. Clearance of secretions of the airways may not be done properly due to lack of medical staff and various reasons. So incidence of ventilator-associated pneumonia can increase. So this chap, he's developed a portable ventilator which can be used to saving lives of these children. And obviously, the adult model can take care of reducing the incidence of ventilator-associated pneumonia. Why I kept this slide is because this is a very path-breaking revolution, and in fact there is a lot of contribution of Indians in medical science. I'll give you another example. I have taught in cardiology that troponin I kit and is one of the best kits to identify myocardial infarction, but there's a new marker available by the name of heart fatty acid binding protein. Now, the development of heart fatty acid binding protein kit was done by a Indian IIT graduate. What I'm not saying that heart fatty acid binding protein was found by an Indian chap. That was found way back in 1980s by Americans, but a kit to identify that was developed by Indian IIT chap, and I got a couple of messages saying that this is not anywhere on the internet and you are just saying it just because you want to tell a story to us. So I want to tell you guys, one, I don't want to tell you any story, I'm telling you facts. And you see, if some company will buy the innovation of this chap, then they will remove all this data from the internet, because then they will sell the ventilator as that of that particular company. So lots of time, like, people make, I would say, advances in medical field, then they sell their research to a medical company, and the medical company will then remove their name, obviously, because they want their products to sell. So that's my justification for heart fatty acid binding protein thing that I have said, and no controversies. I would definitely encourage. And this is again a brilliant chap who's done work on developing a portable ventilator. I mean, ventilator is like, when you think about it, you think about lakhs and lakhs rupees of expenditure. So this chap has done a good job to at least reduce the incidence of mortality related to babies and adults in our country. Moving in our discussion, we will now talk about central hypoventilation syndrome. In central hypoventilation syndrome, which is having a very peculiar name also, Ondine curse. Let's understand what we mean by this Ondine's curse, and what do you mean by the word central hypoventilation syndrome. When Ondine's curse is more of a mythology from Western culture, where there was an individual who was told that when he will sleep, he will die. Even something to that is present in our Indian mythology, maybe in Mahabharata also, But let's not talk about mythology at the moment. Let's be practical. I mean, what do you mean by central hypoventilation syndrome? This is a genetic condition. There is a gene involved by the name of FOX2B gene, which is seen here. Now, let's see the problem related to this. Whenever there is hypoxia, our body will tend to respond by causing a bradycardia. There would be then a breathing effort, a deep sighing and a breathing effort on our part, so that we can increase the respiratory drive and normalize the oxygen saturation in the body. These people either have a poor or absent respiratory response to hypoxia and hypocapnia, which basically means the fact that the sensors in their body that respond to hypoxia and hypercapnia, like in the carotid body, we have sensors for checking for the oxygen saturation in the blood. Those sensors are not working very properly. So for management of these patients, we will have to use a non-invasive positive pressure, intermittent positive pressure ventilation, or we might have to use mechanical ventilation, or the latest treatment for this condition, and that is why I've gone to it, because that's the MCQ, phrenic nerve pacing or diaphragmatic pacing is done for. Then phrenic nerve and diaphragmatic pacing is not done for OSA. It is rather done for central hypoventilation, where the sensors picking up hypoxia are defective. So you need to make this person breathe on a continuous basis, irrespective of the fact that whatever is the oxygen saturation in the body. So in these particular patients, response to hypoxia becomes lesser. Like if they go to a high altitude, when you go to high altitude, your body will try to respond by helping you breathe faster. In this case, the response is lacking. So that's why I said phrenic nerve pacing is not for OSA, it is for central hypoventilation syndrome. I also want you to be clear that I have just taught you OSA, obstructive sleep apnea hypopnea syndrome. Do not mix it with what is called as obesity hypoventilation syndrome. Now, what do you mean by the word obesity hypoventilation syndrome? Is simply the fact that this particular individual, he may not be having that increased daytime sleepiness, or he may not be having this repeated nocturnal awakenings present. All this condition says is that the person is obese, the body mass index is more than 30, and in these patients the PCO2 is usually more than 45 millimeter of mercury, which explains the carbon dioxide narcosis that could be occurring in this patient. So these patients mainly have a chronic daytime hypoventilation. In these particular patients, there may or may not be presence of apneic episodes. So obesity hypoventilation syndrome, as the name suggests, simply tells you that there is a elevated carbon dioxide levels in the body because they breathe lesser as compared to normal people, but the symptoms of increased daytime sleepiness, apneic episodes, hypopnea episodes may not be present in this particular individual. Last but not the least, I would also like to put in some words regarding pneumomediastinum. Why I'm doing it here is primarily because I was talking about decrease in oxygen saturation in an individual. So this condition, pneumomediastinum, is also associated with decrease in oxygen saturation. Now, why pneumomediastinum will occur? These are discussed at various different times in the app. One can be related to pneumothorax, so there could be an alveolar rupture. That's mainly related to the lung parenchyma, and then this is followed by dissection of air below the tissues, which can explain the pneumomediastinum of the individual. Second can be Boyrave syndrome or perforation or rupture of the esophagus. It could either be instrumentation responsible, or it could be rupture of the esophagus secondary to vomiting, Boyrave syndrome, that can cause pneumomediastinum into the patient. And then could be trauma to the neck, that is neck tissues could be damaged, and then this could be followed by dissection of air into the tissues, which would result in pneumomediastinum manifestations in a patient. So, well, what will I do in pneumomediastinum, or to identify pneumomediastinum, I will be doing a chest x-ray in a patient. So let's look at clinical features which would be very characteristic in the form of sudden onset breathlessness in these patients, secondary to the events that I have mentioned. The complaints that are usually mentioned in pneumomediastinum patients is one, presence of substernal chest pain. This may or may not be associated with radiation to the arms. Now in these patients, when you auscultate them, you will get a very characteristic finding, and that is the reason I have spoken about it, that is Hammond crunch sign. One description of Hammond crunch sign is like somebody is walking on snow with heavy duty leather boots, or simple way is you will hear a crunch. Crunch would be like when you bite into a crunchy cashew nuts, or crunch, I would say, for a chocolate, a crunchy chocolate available in the market. So there would be a crunch that would be heard. That crunch would be heard synchronous with the heartbeat, with the heartbeat of the patient. So crunch heard synchronous with the heartbeat of the patient is what is called as Hammond crunch sign, and it is heard better heard by you in a lateral decubitus position. So first of all, you need to remember the fact that Hammond crunch sign is a auscultatory finding of pneumomediastinum. In this particular condition, you will be doing a chest x-ray in the patient, which will be showing air. You can see that this air is definitely present, not below the diaphragm. Like normally you have air below the diaphragm, which is standard Mustat sign of peritoneum. In this patient, I'll erase it now. The air is present just below the heart of the patient. So what we are seeing here and is technically called as continuous diaphragm sign. That's a characteristic MCQ, and you would have anyway done this MCQ and image based question wise also. You should know continuous diaphragm sign is a feature of pneumomediastinum. If you look at the next X-ray, you will again notice air with respect to the heart borders. Normally, there is no air with respect to the heart borders. In fact, this can be much better seen with respect to a lateral view, where you will notice the fact that there is air present in the mediastinum of the patient, and that will lift up the thymus of the patient. So, a Spinnaker sail sign, as the radiologist will say. That's why, because the air will lift up the thymus gland. So, a Spinnaker sail sign. I'll just mention the name here. Sail sign or Spinnaker sail sign is seen, though it's not very visible in this one, but still, what do you mean by Spinnaker sail sign is simply the fact that the thymus is pushed up. The position of the thymus is pushed up by the air which is present in the mediastinum of this individual. And another classical sign, though difficult to pick up in an exam question, but is given classically, is called as Neclerio V sign, which would be seen with respect to the heart borders of the patient also. So I just want you to remember these names: continuous diaphragm sign, then the air is present retro to the heart or adjacent to the heart. Spinnaker sail sign and a Neclerio V sign are features of pneumomediastinum. We will now talk about treatment for pneumomediastinum. There is no definitive treatment required for this condition, because most of the time there is a absorption, there is a self-absorption of the air. So as such, I mean, air is harmless and is gradually gonna be self-absorbed or gradually absorbed, so there's no treatment required. But studies have shown that if you give high flow oxygen to patients on pneumomediastinum, then it increases the rate of reabsorption of this air. So as such, faster resolutions would be seen. And well, if it is causing obstructive shock, then we need to be more aggressive in our approach. Like in a case of pneumothorax, there is an obstructive shock with pneumomediastinum. Like two things are occurring together: pneumothorax, pneumomediastinum. Then in those circumstances, a needle decompression may be required in the patient, so that the air which is present in the mediastinum is such a large amount that it has actually contributed to compression of the SVC and the IVC, and a decrease in the venous return of the patient can be reduced. So obstructive shock is usually going to be seen when you are having a pneumothorax and a pneumomediastinum concomitantly present, secondary to trauma. That is when a needle decompression in the second intercostal space of the patient can be done. So these are the aspects which I want you to remember, especially the radiological science for this topic. And yes, specifically, I mean, I would like to highlight that a good night's sleep is important for performance. So keep working, guys, keep hammering, and the ceiling will definitely, I mean, you will be able to touch the ceiling. And this big obstacle in your course, the last one, I would say like this, the exam that you need to clear, the final PG entrance exam, before things become relatively cooler for any doctor's career, is definitely the dam's wall is breached and you're able to get on to the other side. So well, thank you so much for listening, and we'll discuss another topic subsequently. Thank you so much.